Andrea and Shannon's role play. That was that. I'm almost done with the role play assignments, so that sounds good. Look at you, Jason, jumping on in, being an actor, being an advocate. I love it. So this topic is one of those that was not part of Lend when I did it. And it was more of, I kept hearing things like, well, that's when you'll have the difficult conversation with the family. And I was like, okay, I keep hearing this theme, but when are y'all going to teach us like what to do in those situations? So I worked with the director before Jen, and we created this idea of just building it into the session, because you can be matched with a lot of really, really great clinicians to learn these skills, or you can get good feedback along the way from peers and colleagues and even from families. But you can also have some really not great mentors for this kind of work. And I will say, the first time I ever shared a diagnosis of intellectual disability with a family, I probably couldn't have made more mistakes. I really don't think I could have. It was a hot train wreck, and I felt terrible about it. And I know the family didn't feel good about it. And not saying that, you know, a diagnosis or difficult news or really kind of having to share something that is uncomfortable is ever going to be welcomed. But I think what our a main goal of ours should be in this work is to make it as least traumatizing as possible. I've heard some really horrific stories, especially in the Down syndrome community, about how they literally get a drive-by diagnosis where they've just had a baby, they didn't have a prenatal diagnosis, and then a nurse literally comes and drops off a piece of paperwork that says your child has Down syndrome, and here is a number you can call when you get discharged from the hospital.
It's not even getting a diagnosis only. It's also like when you're getting reassessed as well. I remember they spent like a minute talking about what I was good at and how lucky I was to have a support network, because otherwise I wouldn't be able to do this. In 20 minutes of like, you're going to fail out of grad school because you can't pay attention, and you're really going to need this, and you're going to make sure this has to, you know, and I was like, in 2015 at like children's home, because that's where I had to get reassessed. And I'm not saying children's homes is terrible overall, and I don't know, like, you know, and I don't know how used they were to doing it with adults who are redoing it because of the, you know.
No, but you bring up a good point, Jason, that it's not just, you know, this isn't just going to be a session that's most important for Elodie and Abby and Andrea and James and, you know, our other psychology friends. This is important for everybody, because, you know, Megan, you're going to be in situations where you're doing therapy with people and it's like, ooh, nobody shared this with them yet. Or, you know, I mean, obviously, Shannon, this is your life, girlfriend. But Kim, Kelly, and OTPT, you guys are going to have a lot of this kind of thing come up where it feels like, ooh, this is slightly outside of my wheelhouse. However, I have a really great relationship with this family, and this family has come to see me for a really long time for therapy for their child. And I can make the biggest impact by helping them understand the fuller picture, right? Christy, in your work, this is going to be really helpful, you know, coaching families and kind of being that navigator. And obviously that goes similarly for Pat and Donna and Risha. Anytime that you are kind of an advocate and help out other people through a process where they're grieving or they're getting into action or those kinds of things, to help advocate for them and to help them stay calm, to ask the right questions, help them to even know what is what and what they're allowed to ask for, what they can ask for. So I think I just want to make that point, that this is not just how to give a diagnosis, but more of an extension of how to have that difficult conversation, but in that clinical experience where it might be, I mean, I can't tell you how many times I've had to give a re-diagnosis conversation of intellectual disability because a family sees me for therapy years later after their child left with a global developmental delay and autism diagnosis. And the family heard autism, but the family didn't necessarily hear or understand or really capture the full picture of what a global developmental delay diagnosis would mean in the future. And oftentimes that becomes an intellectual disability, which in many cases the cognitive impact has more of an impact on daily living skills than even an autism diagnosis might. So I think it's those kinds of things that you're going to see this, you're going to have some conversations. This is what being a good clinician really, really comes down to, because we've seen it where it's like, oh, that clinician got wrapped up in their own emotion and really did not pay attention to what was going on with that family. And they may have gotten their message across, but the family didn't hear a darn thing. So this is a nice balance of art and science, I would say. So we'll go through these slides today. There's at least one video that I hope will work. We can kind of talk through it. And then what will happen is you will be assigned to a small group. I think the way that I have it so far is that there's at least you and one other clinician. And I know this is very different from what you would experience in your everyday, day-to-day, right? Like Sam's going to give probably a lot of hearing impairment diagnoses in her life, but she's not going to do that in partnership with Elodie. However, this is going to be an opportunity for you guys to also learn from each other in the moment, to hear how other people explain things, and to hear how others kind of answer questions. So that's another thing that kind of takes some of it with a grain of salt, but also like you can tag team it. So you'll have this information, and I apologize in advance that this preparation time kind of falls right around spring break, because I would like you guys to take as much time away from work as possible. But when we do come back on next Tuesday after the following Tuesday after spring break, we will have about 20 minutes to prepare, and then we're going to jump into the role plays. And so yeah, we kind of hopefully I've divided and conquered people who've had this experience. Like I know Amber and Courtney have a ton of this experience. So obviously you guys are going to be partnered up with people. I think Abby, Elodie, you got Nicoletta, you guys have had some experience, I'm sure. So yeah, gonna divide and conquer and learn from each other as well. So thanks, Jason. Yep, EBKs also do that first day. So yes, good reminder. All right, let's get into it. So the objectives for today, we're going to discuss the reason for learning about sharing difficult news. Like, why is it important to actually have some coursework on this? And I've kind of alluded to it because it can be done really, really poorly, honestly. We're going to talk about the SPIKES protocol. This is the approach to discussing a diagnosis, sharing difficult news that is most often cited in literature and across fields. So there's different ways, but oftentimes anything is done from a research perspective. It's evaluating the use of the SPIKES protocol. And then I want you guys to think about over the course of this week and in 2 weeks after spring break, how you can improve your own approach to delivering, sharing, communicating difficult news. So obviously this encompasses and overlaps with a lot of MCH competencies. Self-reflection is really checking in with your own internal sense of fear, anxiety, how much ownership do you feel you can take based on your discipline and your training versus what needs to be communicated to another health provider to make sure the family gets their needs met and their questions answered. Ethics and professionalism, I think, again, is really important, is knowing where your discipline's scope of practice ends and where another begins and where those overlap for the betterment of the patient. Critical thinking, obviously, right? I always kind of think through what can I do for a family when I'm thinking about a diagnosis, when I'm thinking about changing a treatment plan, when I'm thinking about, saying, I really think that it's probably time to stop that speech therapy that you've done for 2 years that you're not finding benefit from, right? Like what can we do to be thinking critically about how to have these conversations, but also to communicate with families and patients that I'm thinking ahead for you. It's hard to not live in the day-to-day, and I'm trying to help think ahead for your child, for your family. Communication is the how we do this well. And then obviously cultural responsiveness, competency, that is going to be part of everything. Who is involved in the room? What, how is eye contact done? Those kinds of things. And unfortunately, I believe that we only have typically one non-white actor with us. It's something that we always ask our friend. So our lead actor connection is Jen's sister-in-law. She's an amazing actress and she has a lot of friends. But unfortunately, the people that come year to year, we only have one non-white person. So we'll see who's coming this year. I'm not exactly sure. Family-centered care, that goes without saying. And then interdisciplinary team building, I already kind of alluded to that you're going to be doing some things that would never happen in real life. But that's okay, because we can learn from each other. So I've already mentioned the disclaimer that there's going to be peer feedback and role plays. So get ready for that. You have 2 weeks to prepare mentally for role plays that I know some of you are like, I hate a role play. And other people are like, we do role plays all the time. Role plays are no big deal. This is our agenda. So rationale, communicating difficult news is really complex. There's a lot of fear that gets wrapped up in it. There's a lot of complexity now as a result of COVID, and so much is in a virtual world. There's concern for kind of being the face of what some families have referred to as D-Day or Diagnosis Day. And really that is a very traumatic experience for family members. It can be a traumatic experience for the patients. And I think, even Jason, I'm gonna allude back to what you said. You got animated and kind of emotional, even reflecting back on that experience you had in 2015, yeah. Right? So like you carry those kinds of things with you because, again, we think about a diagnosis in the medical model of we have this quote problem, we have this symptom, we have this entity that we can put in a checklist, come up with a diagnosis and match it to a treatment plan. And so again, a lot of these things are wrapped in a lot of complexity, emotion. I think for a lot of what I've seen in the research is that clinicians withhold information for a couple reasons. One, if they don't necessarily know the answer, right? And I can't tell you, if I had $1 for every time a family asked me, well, will this child do X when they're older? Will this child live on their own? Will this child talk? Will this child ever not have aggression? And those are kind of questions that as clinicians, we can do our best, but we will not be able to answer with certainty ever, right? We know what we know from research, we know what we know from our clinical experience, and we know what we can do to coach families to own and be part of that team for their individual or for themselves. But we don't know the answers. And I think that that's okay to say, I really don't know, but here's what we do know based on what we've seen in other kids or other adolescents or other families. There's also this mom effect of, if I just kind of keep quiet about it, then, I would much rather share good news than share bad news. Can you think about all the times that you're like so excited to share good news, but sharing bad news is kind of like, oh, this feels so uncomfortable, I'm just going to keep mum. And so there's a lot of that we see in the literature that leads people to just not communicate. And what do we know happens in teams, in families, in relationships when we don't communicate? Come off mute, put it in the chat box. What results with a lack of communication? Maybe what behaviors, what emotions do we see?
Maybe like frustration because of miscommunication.
So frustration for sure. Yep, misunderstandings, breakdowns, lack of trust, right? So Christy, come off mute if you don't mind and tell me more what you mean about assumptions.
I'm just like misinterpreting possibly the message or already having things preconceived in your head.
Yeah, for sure. Yeah, misunderstanding, frustration, resentment is a huge one. And I think resentment and trust and mistrust go all together. Maria put secrecy, that's huge. And when we think about our role as clinicians, our role as advocates, and anytime you are working as a professional in any entity, you are being looked at as the face of that. Has anybody had the experience yet of like, oh, you work at Children's, do you know so-and-so? No, there's 16,000 employees. I have no idea who that is. Everybody outside of Children's thinks we all know each other. And if they have a bad experience in urology, we should know about it, right? I'm like, I don't even know anybody in urology, but you had a bad experience at Children's. So we are the face of Children's, right? So if they have a bad experience with us as a clinician, that's going to carry over into trust throughout the institution or throughout any agency or organization that you work with or for. So
Well, I think too, it can also, especially with all these other things, and especially, you know, sometimes I've heard of like parents and stuff who get it where your child's never going to do this, and some of those things, that it can also give distrust, not in just children's itself, but the things that go around those sort of things, the actual science or the methods or the field of study or something.
Absolutely.
Well,
absolutely. And I think that brings up a good point of like, it's all about the bedside manner. And I think that that's not often well taught across fields. Is that kind of what we think of as the soft skills, how do we approach a family, a patient, a diagnosis in a way that is not completely off-putting and stoic, so that families leave feeling that they were heard and cared for, and that they do have trust in that whole healthcare system. So yeah, excellent discussion there. We know from research that has been done on how families like to receive difficult news, and this is across not just developmental disabilities, this is across cancer, this is across a lot of life-threatening conditions, that kind of thing, is that families do prefer a familiar care provider. And this is always such a trick for me, because as leaders, you are going to be faced with difficult systems level issues and systems level challenges. Do one of my psychology or pediatric friends want to talk about how our diagnostic process looks, or maybe somebody from my SEVM team want to talk about what that looks like currently in DDBP for those that aren't in the thick of it every day?
I can do that.
Thanks, James. Go for it.
Long story short, it's exceptionally long. And we have families that come in and they've been on the wait list for a while. They've been referred months before they finally get their appointment. They finally come in. It's a long appointment when they do come in. So for our arena visits, they're usually 4-hour appointments for testing with a psychologist, and also usually with speech pathologists as well. And they have to wait another month or so before they even get the report and get that diagnostic or those diagnostic impressions and the recommendations and referrals. And then it's months after that before those referrals are actually follow through in terms of coming off wait lists or scheduling visits. So like for some families, it could be a year from scheduling an appointment to receiving their first intervention.
And who typically does what we call the information sharing session, or the ISS?
What was that?
Who typically does that? What provider?
Usually it's the psychologist, but oftentimes it can also be the developmental pediatrician.
Yep. And so basically James and let's see, James could be the psychologist and Kelsey could be the speech language pathologist who see a child for an evaluation. They do their evaluation, they score up the reports, and then 2 months later, that family comes back and sees Elodie, and Elodie shares the results of the appointments and the diagnoses with the family. They've never met Elodie before. So that is completely contradictory to what we know from research, that a family wants somebody that they're at least familiar with, right? So, however, let's put this back out there. A place like an institution like Cincinnati Children's, and especially DDBP, we get over 800 referrals per month. And we have, I don't know, 25 psychologists and maybe 12 pediatricians. 800 kids per month that are brand new. From a systems level perspective, it's hard to wrap your head around that volume of numbers of families that need to be seen. And that's the new families. That's not even the families that come back for ongoing care and ongoing therapies, right? So we're always working on trying to do different models, different ways of getting families from referral through to information sharing session in the quickest possible way. And unfortunately, sometimes that means that a family comes and sees a provider that they've never met before. And that's why I think the One SCBM project that we're working on is so valuable, because we're getting direct feedback from families on how their process went for them, so that we can make improvements based more directly on what we hear from families.
I have a question about that really quick, because I mean, just depending on the thing too, probably the first time they're meeting with a psychologist or the speech person too is probably the first time that family has interacted with that person. And it doesn't necessarily mean, essentially, because it's not somebody they see regularly, like their primary
Right.
or something, that there's the best relationship. So, I mean, I guess that goes into my point in question, like, is that, so it sounds like, is that something that's being, like, that's what sort of this project is doing, is just seeing how, like, people feel with, like, meeting and some of those things that you can do to make a family feel more comfortable as meeting a bunch of different people. I forget the project. I'm sorry for all.
Yeah, no, our project is really looking to see if there's differences in how we provide recommendations and resources to families based on their race and ethnicity. But as a byproduct, we're getting really great information on the issues that families have, or if it went well. And so we will be able to take that back to the teams to say, hey, this is, we want to be better, but we're getting feedback from families. So yeah, Kelsey put, and if a family misses one appointment due to illness or a number of other reasons, it's likely that all the future appointments will need to be rescheduled or postponed. Oh, and they ran into that today. And then James is on the project that I referred to, and he spoke with a mom that we recruited who is still having trouble accessing her child's eval report. And this is diagnoses pre-COVID. So just lots of things that lots of families walk in our doors, lots of families walk out of our doors. And it's all kind of goes back to how familiar are you and how likely are you to follow back up. I would love to also do a research project to know how many times do we put in a report, reach out to our social work team, reach out to our family navigators, and how many of those families actually do that on their own without our folks calling them, right? So if they have a question in their report, do they call back? Or do they just go without their questions answered? And I think that latter happens more than not. The other piece that I think this is really important is those familiar care providers become you that are the therapists, become the folks that are seeing families regularly in OTs, PT, speech, regularly for your, hearing aid checks and those kinds of things. You become the people that can really have the most impact on having a good quality interaction and making sure that people get the information they need in a way that they can kind of let their walls down and let it in. Again, this isn't rocket science, but families want somebody to be honest, have compassion, and be clear in their messaging. So the more anxious that we become, the more we dance around our words, the more we kind of hem-haul around. They want people to be clear. They want you to just kind of be matter of fact, but also bridge that gap of not being so matter of fact that you're off-putting or you're too stoic, right? They want you to be compassionate. They want you to show that you're human. And I think it's hard because many of us were trained like, you never show emotion, like, whoop. And it's really hard to not have that emotional contagion at times, especially the more you get to know a family. Or I can't tell you how many times my eyes have watered when I see a family crying. And that was in my training. No way, Jose, you do not cry. Like, you don't touch a patient, you don't cry, you don't show emotion. And I think that's really, really hard. And that's not what families want. They want us to be human. Just checking the chat box. Yeah, and Kelly, you bring up a good point. Right after that ISS, sometimes families will say, I heard the word autism and I shut down completely. And, I remember when my one girlfriend got the phone call from a genetic counselor and they did the prenatal diagnosis over the phone, and she got that and she basically heard nothing, hung up, and was, just in shock for a few days. And wasn't quite sure, what to do next. And so that is why we ultimately built the Family Navigator program, was to make sure that we had somebody to contact families a couple days later, a couple weeks later, kind of keep checking in on them. And my guess is, Christy, that's kind of what you're doing now over at the Freeman Center, right? Some of that, like checking in with families, keep making sure a few days after their appointments that they have somebody to
That's
talk
going to
to.
be the goal. Yeah, that'll be the
Okay.
goal of the future position. That position isn't created quite yet. So right now I'm working on a grant, but that will be the goal, is
That will be the goal.
connecting to
Yeah.
the community, follow up for the families. Yeah.
And there's tons of research, especially in cancer, that is an integral part of the healthcare process, is that navigation, that patient navigation, family navigation. So yeah, I'll just stop there and see what thoughts people have. Courtney, Amber, is this some stuff that you guys probably have already covered a number of times?
We've had a couple lectures on, breaking bad news, and definitely have practiced in a lot of role plays, different ways to do that. And I think Courtney and I have both had to do it with patients in real clinic appointments as well before. So
Any additions that you want to add to share with your friends that we haven't maybe covered yet?
I just reiterate, like, showing emotion isn't a bad thing. And I know, like, my summer supervisor was like, I have cried before in front and with my patients. And, you just have to be aware that your patient doesn't become the comforter to you. And as long as that doesn't happen, then,
Exactly.
it's generally well accepted and appreciated that, the patients know you're hurting for them too.
Yeah, I would just add, like, I really focus on letting the patient lead. So I go in there prepped with all the information that they could ever ask me. I try to, at least. But knowing, like, I don't have to tell them that all right then and there. Some families just need you to listen to them, whereas others will want all of the details that you have and probably answers that you don't have as well. So I just try not to go in with any, like, expectations. Also, some families are really, like, you expect it to be awful. I'm doing a case conference this week on a similar case, and you go in there thinking this is going to be intense. I don't want to tell them this. And they're just, like, fine with it. They just go with it. So you never know what people are how they're going to react.
Yeah. Thanks, ladies. I think that you bring up a couple of good points that I want to share too, is that when I was a practicum student, I was on a research project where we asked families, what was your main emotions? List your top emotions after your child received a diagnosis. And the top two were empowerment. They felt empowered, and they felt relief. Because more often than not, this isn't coming out of the blue for a family, right? They're coming to the hospital, they're coming to a medical provider, they're coming to any kind of healthcare provider because they saw the concern. Less often do we have a doctor in the community referring in and the family's like, well, I don't have any concerns, right? So it's more of that, oh, this is great that somebody is reiterating my concerns and they're confirming that for me. So I think that's really important to keep in mind too. And Courtney's right. There's some families where you're like, whoa, like that was going to be, in my mind, the hardest thing I've ever done. And okay, I feel like we were able to have a good conversation and get to a good place of action step too. Versus I still have a buddy who is like near and dear to my heart. And I think we did the family a disservice by letting them jump into action far too soon. And I mean, literally to the point where they got a diagnosis on a Tuesday. On Wednesday, they were at a therapeutic programming session, making a game plan for the therapies. And I think that left, especially the mom, wrapped up in too much grief and emotion to really even think through how to take care of herself. And I think that really impacted his carryover of care for a long time, unfortunately. So, oh, I'm sorry, Jason. Let me send a text really quick and I'll get that on. Huh, you're sweet. I'll work on it on the break. Okay. All right. So I'm going to skip this for time. So why we should practice, because all communication is a trial and error process. We definitely are not as good as we think we are. And we can only improve by having a plan and getting feedback and making small changes. We don't have to make huge changes session to session, week to week, month to month. You know, this is why fellowships last 1 to 3 years. We don't expect you to be able to do this perfectly overnight. And honestly, there's a lot of providers who continue to work on it, as they should, right? That's how you know they're good providers, because they're constantly working to improve. So, and I think about this based on something Amber had said too. We're always working on the communication with our spouses, with our partners, with our family and friends. So this is no different. Any of these heavy emotions goes back to what we talked about in the crucial conversations sessions as well, of how do you regulate your own experience, and how do you kind of have that self-regulation, emotional awareness, reading the room ultimately, so that you don't steamroll people with information, or you don't steamroll them and then not give them a chance to emote, because that is a big piece of this. So the 4 goals of sharing difficult news are really to elicit information from the outset to make sure we're all starting from the same place, or that you at least know where the patient or the family is starting from. The goal is to provide information. The goal is not to provide all the information, but the goal is to provide information based on what the family or patient asks, or what you as the clinician use as your educated guess on what the patient needs at that time. And then a huge component of it is supporting the patient and the patient's family with their emotional response. And then it's always a good thought to try to end on, how do we take a next step? How do we get to a plan? You may not get to that in one conversation. And I think that this is where systems level issues get into play, where unfortunately for Elodie, Abby, Nicoletta, they get 30 minutes to share a diagnosis. Whereas our psychologists team, we get like 50 minutes because of insurance, right? How silly is that? It has no difference. Like, you still need to share all of these pieces of information, understand the emotion, respond to the emotion, develop a treatment plan. And because insurance tells us, no, one provider gets 50, one provider gets 30. What does genetic counseling typically use, Courtney and Amber?
It's super dependent on the institution, as far as I know.
Okay.
Like at Children's, I think they would give us probably 30 minutes to an hour.
Yeah.
But at my summer rotation, we didn't bill for our services, so we could sit in the room for like an hour and a half with the patient if we wanted to.
Yeah. And that's a huge
It's interesting to
difference.
think for Andrea
Yeah,
and general pediatrics too, because there's still diagnosis that we make not in specialty clinics, and you have 15 minutes and it's just supposed to cover well child, any concerns that family have, and anything else. And it's like, I can't get through a parent's questioning, let alone try to even start to cover what they want us to talk about.
Right, exactly. Such a good point, Nicoletta. So then that's a great point, is what you come up against as clinicians in specialty care is families who've had that experience potentially, where they don't get their needs met because they really only get 10 or 15 or 20 minutes with their primary provider. Yeah. So again, I talked about this in the learning objectives. The SPIKES protocol is what is most often referenced in the research. And we're going to go through each of this letters of this acronym and kind of talk through what that looks like, but we'll take a break at some point too. So, well, let me go through. So the whole SPIKES protocol, obviously each letter stands for something. So you have your setting or your environment, getting that patient's perception, getting an invitation for how they might like to receive the information, or what particularly they're most focused on, just giving you a little bit more specifics about what their interests are in that, and how to use the time. Then you give the knowledge or the information. Then there's that emotional piece, and really, reading the room, being empathic. And then this S is strategy and summary. And sometimes you get to summary and not to strategy, and sometimes you kind of think through and you got to bring them back. And that's what I think is the most frustrating, is sometimes that our systems don't allow us to easily bring a family back, which is why we rely so heavily on navigation, social work team who are amazing, because we can say, oh gosh, I know that mom or that dad or that grandma is going to need a bit more emotional support. And we say, hi, Shannon, I got this, this is where I left off. How can you help me? And how can we get them back in to see somebody, but it's not a readily easy experience to get families back in. Because again, 800 referrals a month. So setting up the session, the S, really, this is when we want to make sure that the environment is least distractive. This is when I oftentimes leave my cell phone out of the room, leave my Apple Watch out of the room, make sure that I can try to provide as much privacy and one-to-one interaction with the parent or the family or the patient as much as possible, give them my full attention. This again can be really challenging. And what I want to caution some folks that maybe do therapy is you might get doorknob confessionals or doorknob questions where it's like, oh, I'm about to finish this series of treatment with this family and they're going to stop me and ask me for a bunch of questions in the hallway. Nope, we go back in the room, we sit down, we try to get through what they need to get their questions and answers met. And that's what's hard, right? And you're balancing staying on time and doing all those things. So a lot of it too is being proactive and trying to work with, if you are a therapist, working through some of those things as you go or over time versus, I'll never forget this one mom. It was our very last session. We were getting ready to leave and she's like, so will he ever live on his own? And I was like, oh man, like we could have talked about this for so long before. And now we have literally no minutes. So the other option is to go back into some privacy and use that time to set up another appointment or set up a time to call them on the phone, something like that. And this is some of these instances, you don't bill for your service because it is more of just going kind of above and beyond to meet your patient's needs. The P, the perception, is getting the patient's perception. So it's always before you just jump in with a bunch of information. I always recommend asking for how people learn, how they like to receive information, and really just getting an understanding of what they thought they were there for. I don't know, has anybody thinking back to the ITT cases last semester, was there differences in the way that you guys saw the different family members receive the information? Like how they liked it?
This isn't necessarily from the evaluations, but sometimes my patients will prefer to have things written out, like a summary of what we talked about versus sent to my chart because they feel like they'll lose the paper. I also just find in some of my sessions that when we're practicing interventions that really require the patient's parents or family providers to participate, some just prefer to watch, versus some really want to get their hands on and do it right then and there so I can give them feedback. So those are some differences I see in the PT world.
Awesome. Thanks, Kim. Yeah, and I think I jumped ahead. So how they like to receive information is more of that invitation. So we'll come back to that. But really the P is more of just like, what do they understand why they're there for? And kind of this is your opportunity to go back through. So you saw you saw the speech path and they looked at expressive language and that's what this means. And they looked at receptive language and that's what this means. Or you can be more open-ended. What did you gather from watching your child go through the psychology evaluation with so-and-so? And again, this is challenging because you typically skip over this when you have 10 or 15 minutes. But this can really help gather information and you kind of become the detective to figure out, oh, what nuggets do I really need to hit multiple times? Because we all know that we all need information multiple times before it really sticks. It's not, one, subpopulation needs it more, or people with attention concerns. No, we all need to hear things multiple times. That's just the way that human nature is. So this really helps us kind of clear up those miscommunications or any misinformation along the way.
Hey, Steph.
Then go ahead. Yeah, Kelly.
Oh, this just reminds me, I have a patient who is scheduled for an arena and an ISS. And I kind of asked her, I was like, do you know what that's for? And she had no idea.
Probably not.
And
No.
I was like, you're scheduled for these long appointments. And I kind of walked her through some of the stuff she is aware of, like autism. She kind of questions it too. So I was able to be very open, but it blew, like, I was just shocked that she had no idea what it was.
Yeah. Well, because it goes back to a lot of what Nicoletta was describing. You have, you go in and you tell your child's pediatrician, oh, I'm really concerned about speech. And then they might not even tell you that they put a speech delay diagnosis in the chart. Or they'll say, okay, well, I'm referring you to Children's. Here's your green pad. Here's the number to call and make your scheduling. They don't necessarily have time to explain it. And on top of it, they don't even know. Our darn processes change all the time. They don't even know what to tell families, to be honest.
And like, I
work in the division and I don't know what the hell we're doing with diagnostics. So right. I think that there's that component. And if that was a great way to step in, use your expertise, use your relationship to say, well, this is what you can expect. Another really cool thing that we're leveraging our Family Advisory Council to do is helping families know what to expect by making some family-friendly, like basically a social narrative of what you can expect when you come for an evaluation in DDBP. And we're trying to make it as broad. The trick is making it broad so it applies to everyone, but making it specific enough that it's worthwhile. So that's on the horizon, but it's really, something that the community pediatricians that make referrals, they don't know what this process looks like and even really necessarily how to help families. So yeah, that's awesome to help them understand what they're even coming for. Because the other thing is that oftentimes in the system, we get referrals that say R/O ASD, and that is literally it. That means it's a question of a rule out for autism. And that's what the pediatricians have time to put in the referral. And so we don't get much information either to even kind of help the families know, well, what did the pediatrician, have as concerns, or what do you have as concerns? So again, going back, getting their invitation. This goes back to what Kim was saying about some people like to learn differently. And what was one of the first things we had you guys do over the summer? The VARC, right? How do you like to learn? Are you visual? Are you auditory? Are you reading and writing? Or are you kinesthetic? Everybody is a combination pack of any of those. And so I am a person who likes to write. And so I love being in the one, Kate and I treat a lot in the classroom with the whiteboard, because like I've told you, I like to be an educator. So we'll draw things on the board and we'll write things out because that helps me teach. But sometimes with families, that also helps them learn and take in the information because they need to see it too. Or the families that really need to act it out and do it before they can do it at home. That can be also, more of that kinesthetic learning. But you gotta kind of get an idea about how the family wants to take in the information. Some other ideas that we have more flexibility, I think, to do in ITT, which is why we like, to kind of do whatever you guys as a team think is best, and why we have our family representatives helping us out. Sometimes families just want a one-pager sketch of what are the top highlights, right? Versus other families are like, I'm going to go through every report with a highlighter and a fine-tooth comb. I can tell you that I have a huge stack of Easton stuff and I've never read it word for word. I'm like, oh, yep, that looks good. Like, this is what the problem list is. This is what the diagnosis is. I'm never going to read a report word for word, right? I want the high level. I'm the person that's high level. Let's figure this out. So you got to kind of get to that place with a family before you just start jumping in. Then we have more of, in some of the literature, this is called a warning shot, but I'm like, oh God, that sounds so terrible. Like, no. just kind of a preparation statement or a warning statement. So it's more of, our team was able to get really good information. Thank you for filling out all of those report forms and getting the teacher and the childcare provider to fill those all out. We were able to come up with what we think is a really good description of what's going on right now. And we have a couple diagnoses that we can share with you. So it's not just saying, well, our team thinks it's autism, right? But more of, let me kind of let you know what's coming, that I'm going to say a diagnosis, or I'm going to give you a picture, but not just going to necessarily rip the Band-Aid off, but it's coming. So using vocabulary that's understandable. And really this is so hard for us because we live and breathe this so often, but trying to avoid any professional jargon, specifically acronyms, or being excessively blunt. This is where families can oftentimes report feeling like just blown off, feeling like the person didn't care. Just they were another cog in the wheel, another patient that the doctor had to see that day. So I want to stop here and just see what reflections folks have thus far. Chat box or come off mute. Anybody that's received that.
I'm curious because I don't know this as much, because for some people this might be more of a skill and for some people it might be. Do hospitals do that as sort of teams for, and sort of be able to meet with it? Because I'm not saying that like this isn't good for everybody to know to some extent and stuff. I'm just curious because, when at least, even with just team building in other spaces, a lot of times, and it sounds like sometimes you're just like everybody's supposed to be everything, having to sort of teamwork sort of build into of who sort of, I don't know if that's something the children's already done and it seems too I'm sorry, I don't know if I'm making any sense.
I was going to just kind of speak to that. So I appreciate and value that this is being taught to so many more. When my brother was born, the doctor came in and just basically they had some complications prior to the pregnancy. And then, Michael was born and they said, everything's great, everything's fine. And then an hour later they were in the room and the doctor came in, my parents weren't even together, and just said, oh, we're sorry, you're gonna have to call everybody back. He has Down syndrome, and walked away. Like didn't explain anything, didn't give her any paperwork, which the DSAGC has worked really hard on making sure that paperwork is more available upon diagnosis. But just knowing that hopefully families don't have that type of experience is so important. My mom bawled her eyes out, in a room by herself, and thank God there was a nurse that was there for her. But that experience is one that we hear very, very commonly for individuals that were previously diagnosed with Down syndrome. And we're starting to see that shift, which is so, so important. So I value that people are getting that knowledge.
So Jason, are you asking if other places around the hospital, not just in the LEND program, are folks getting training similar?
Well, I guess it's that is folks getting training, but also like that if there's these team-based approaches to some of this, that if for somebody who really, because some people's personalities or the way their mind work, they do it without even realizing, and as much training as there are ways to sort of support people in other ways with teams that you have, sort of different people who can sometimes, because if I was expected to do everything at the work I did and my things with executive functioning, obviously that's some of my disorder as well. I would be in a tough thing if I was always, or if it was always so like being able to be like, this is the thing I'm like having sort of it, be like, okay, this person may be better at this sort of thing. And sorry, I'm not trying to make it like that nobody should learn it, because I think everybody should learn
I think
about
I get what
it.
I think I'm kind of following you, but it's definitely like there's certain folks that at least in DDBP, there are certain folks that are more of the diagnosticians, and maybe they're the ones that are assigned to do the evaluations and the information sharing, versus others are like for me, I'm not a diagnostician, I'm more of a treatment provider. So we all kind of play our roles, but I think what you're getting at is really important about the interdisciplinary team. It's getting the right people in the right seat on the bus. So if you have somebody that
Yeah.
Go ahead.
Some of it is, I mean, it seems like too, like it's about the personality of somebody. And if it, because I mean, just in general, we all have personalities we gel with or don't gel with as much. And there's some personalities that are more, that are more, like aware of sort of or the social element. And you get some people who are just like, this is the diagnosis, this is it, even with some of the teams on lab, like one of the people who's the financial guy, he's blunt, he's sort of like, what is the means of this? And I don't know if I would have him talk to everybody sometimes, or specific, like, how do we like navigate that? He's obviously really, really good at what he does, but maybe there's somebody else who's also in finance or who's on to something else who might be better to talk to. Sir, I don't mean to sound like restrictive or like people shouldn't learn or like people can't do it. I don't mean to be like that.
I think that's why folks, do programs like the LEN program or do ongoing leadership training or ongoing clinical care training, because they want to figure out, okay, where is my niche? Where is my skill set best served? And if I don't have that skill set, how do I build up people around me that do, right? Like I know over the years, I've gotten far out of understanding all of the community resources. And it's because I'm so darn spoiled because our social workers are fantastic, right? Like that is their like bread and butter, and they're so good at it that I don't have to be that role anymore. And I think that that's where healthcare is, we're in just such a place that there's not as much teaming as there once was. So when I was doing training, we would literally see a family all day, do all the evaluations, and then we would spend about 40 minutes talking about the diagnosis and the evaluation results. And then we would have multiple people go in and share the diagnosis with the family. It was the longest day in the world for a family, right? However, we got so much time learning from each other, sharing information across in live time, like in real time. That does not happen anymore. So if Abby and I share a patient, we have to, oftentimes my chart message, or we have to, I have many patients who I share with psychiatry. I have to get their cell phone numbers, call them randomly on a Friday when I don't have other patients. There's a lot more time and effort that goes into that teaming aspect that you're kind of getting at, Jason. Like, how do we find the right people? Or if I had a conversation with the family, then how do I pass it off to the next provider they're going to see so they can pick up where I left off? Right. And it's just there's just not enough time in healthcare at this point in the world.
It sounds like even
at really do a lot of that communication electronically.
Well, and it sounds like even at Children's, where there is some of that plan, the infrastructure still is sort of not 100%, like 90%. I don't know, because it sounds like it's better at Children's in a lot of ways, but it's still not always set up that 100% teaming. Sorry, not to be mean.
No, And Nicoletta, oh my gosh, I'm sure your life is so much different now that you're in DDBP with social workers, right? Like, where are you on my screen? I don't even know where you went. Where'd you go? Yeah, there you are. Like, how
Prime Amherst, but yeah,
oh my
it
gosh.
was impossible. And so residents in the NICU, when you're first trying to help diagnose these families, and even within clinic, changing from resident to attending, I was constantly behind. And my foreman stepped up where they could to help out. But and we're not given the guidance on how to help these families either. And so you're trying to decide, hey, their TRICARE, are they getting sent out to the community? Are they being sent to military facilities? What's even happening with insurance, which we deal with so much here too.
So you're trying to be the case manager, the social worker, the counselor, the doctor, everybody all in. And in some cases, you can do that. But in other cases, it's like you can be the jack of all trades, but master of none. And that's how you feel at the end of the day, unfortunately, at times. Yeah. Andrea, sorry, I see your hand up now that I've closed my window. Stop sharing.
No, you're good. The one thing I was going to say, maybe we're going to talk this in the future, but what it has helped me with, bad diagnosis or, these high emotional diagnosis is also making sure that if you don't have a social worker or that help us, in the clinic, is making sure that the family is there. Like we assume that a family unit is mom and dad, and maybe dad is working, but sometimes that dad wants to be there for these things because after they hear that they work autism, the only thing that you will be hearing is a beep and nothing else, and maybe dad will catch a little bit of parts, or if it's a single mom and the support person will be grandma. You know, when I had like cancer diagnosis, I make sure that over the phone I tell them, could you please bring whoever is closer to you, or even the best friend, because sometimes we, like I said again, we assume that family unit, and we need to make sure that we're providing all that information to the parents. And then I feel that I'm saving myself some time later answering calls and having them bringing them back, because family is able to recall some of that information instead of me having to bring them back multiple times to tell them the same thing. So I still struggle with, like, how much information do I give on the first visit, and I'm always running behind. And I'll appreciate any advice about that. But I have felt that doing that, it has helped me a lot.
I love that you brought that up, Andrea, because that it was definitely something that in years past, that's what we encouraged families to bring their early intervention provider, or the neighbor who the family member felt really comfortable with. Because on top of that, when you come for an ISS with a pediatrician, the child has to come for insurance purposes. So you really almost need like somebody to help watch the child when mom or dad or grandma or aunt or whoever needs to take in the information. And that is just not built into our system very cleanly. So I think you bring up a great point of always, if you're the provider, or even if you're Kim or Kelly seeing a family that is your patient is going for an eval in a different department, to say, don't worry, you can bring whoever you need. Bring your support team with you. It's okay. The more the merrier, oftentimes. I know COVID has made restrictions, but we're not going to turn a family away, or we'll put a family on telehealth at this point. Oh, you want grandma to listen in on telehealth? Let's set that up for you. Right. So great point. That's a great point to end on, and we'll take a break, and then let's come back at 2:15, and we'll finish up and hopefully be done with like 15 minutes before the next thing starts. All right, I have 2:15. So jumping back in, the addressing the patient's emotion piece, I think, is one of those things that comes naturally when you've had some training in counseling, or when you know, kind of serve as that role in your own personal life as the listener, as the person that can kind of hold people's emotions for them. But that's really what kind of boils down to. And this is just an example of a 4-step empathic response to really give people an idea of, you know, when you're practicing, these are the specifics that you could work on. And it's observing the emotion and naming it, kind of goes hand in hand. So for example, I think we've talked about this in the difficult conversations session of sometimes the emotion that people are showing doesn't necessarily match what you think they're feeling. And it's okay to name that. So people might, you know, giggle, but they're really anxious or they're really upset. So pointing that out, you know, noticing that, you know, you're giggling a little bit. Tell me what's
My mom does that. My mom does
it
when she burned my birthday cake, and she just was laughing hysterically while it was on fire, which was fine that she was laughing, except for the fact that we had to put it out still.
Oh.
Sorry.
No, you're fine. You're fine.
And it's an anxious laugh or something.
Yes, totally. A lot of people have that reaction when they're anxious. I think the other thing too is to just name and observe the emotional response too. You know, it seems like your eyes are welling up. Tell me what's happening for you, or talk to me about what you're feeling. And that's kind of when it says using open-ended questions or statements. That's all it is. You know, let me know what's going on for you. You know, do you want to continue? And if so, how do you want to continue? Other examples from folks that you found in your work that's been helpful?
I think also just like affirming the parent or guardian that's there, that like a lot of the times when I talk to parents, they feel like they're doing everything wrong, and it can be really overwhelming, and just affirming them that like them coming to the appointment is really important, and like them showing up for their child is just like a really great strength, and just trying to work from a strengths perspective and apply that to the session, because it can be incredibly difficult, and like the parent can view the diagnosis or disorder as like a failure of them. So
great point, Shannon. Yeah, thank you for bringing that, because it could be, you know, this is overwhelming. This is just a lot of information, and you being here shows how much you care for your child. Absolutely. And those are the like I always talk about this in behavior therapy with parents and caregivers. Less is more. Oftentimes in these moments, less is more. When we think about our interactions with our significant others, many times they don't want us, you know, we don't want them, and they don't want us to fix the problem. They just want us to listen. And that's really what this piece of it is sitting and being with, sharing that space, holding space for people, and just saying even the shortest phrase of, I'm right here, I'm ready to move on when you're ready to move on.
I think too, also being able to be reflective and telling them that they're doing a good job, and it's not their fault. A lot of times, and even historically, we had like autism refrigerator mothers who would be like, because they weren't caring enough. So and now with even genetics and stuff, there's a lot of things of like, oh, well, this is on the parents, or you should have, you know, and that the parents are doing, you know, or that you're just, you know, having a child who might not have attention is just not training them or making them behave well enough.
Mm-hmm.
Sorry,
Yeah.
not to.
No, I think that's a great point. And I think James is kind of following up to that in the chat box of, he often tells parents that the developmental diagnosis has nothing to do with their parenting, but more with how their child's brain is developing at that time. And I think that's another piece. You know, this is just a snapshot of where your child is. You know, once we can always take a look at this again after we get evaluations after we get therapies put in place in school and things like that. And Kate added, it's great to point out, she hears a lot of self-blame and self-doubt from parents. And she always makes sure to check the room for tissues, because crying without tissues is not fun. Yeah. And so I want to stop there and just kind of be able to see you all.
I want to say I've used the pandemic for somewhat of a help, because I've had some telehealth visits that were unexpected, and I've had the kids at home, and I've had my 2-year-old come running in the room in the background and screaming, "I'm naked." And so I'm able to tell parents, like, look, you're concerned about your child's behavior. I'm a developmental pediatrician, and this is my job. And my kid is yelling to you that he's naked in the background. So I was like, you are doing the best that you can. And I was like, thank you for your patience dealing with whatever my kids are screaming, as you've all seen them on screen dreamland. You just don't get to hear them. So I think in some ways, telehealth has been helpful for some of these, because it's like, hey, look, we're all doing the best we can. And even doctors, even psychiatrists, like anybody has struggles. It's
exactly. Absolutely. Somebody else was, what are people's past training or past interface with tissues? And I bring this up because I was trained under this interesting psychology model that we call generalist. And basically, I had some interesting psychodynamic and psychoanalytic professors that would say, well, if you offer a tissue, you're communicating to a family that they need to clean themselves up, or to a patient that they need to clean themselves up. And for me, I'm just kind of like, well, hell, if I don't want to be sitting there snotty without a tissue using my sleeve. So I want to make sure somebody feels good. I don't know, Shannon, go ahead.
Yeah, I was just gonna say, I was observing in complex care today, and the mom started crying, just like she was a very medically complex child, and also just a very socially complex situation, and she started crying. And I don't have any specific training on how to use tissues, but I just held the tissue box in front of her, and I felt like it was just also showed her that I was actively listening to what she was saying, and all the heavy things that were kind of coming to a head, that it was okay to express them and let them out by offering her the tissues. And I don't know, I feel like I would offer someone tissues. I don't think it's a bad thing.
We also have been told, if you're taking your board certification exam, the right answer is never offer a tissue, for the same reasons that you were saying, Steph. But in clinic, I definitely would offer a tissue. So yeah, I don't know. I guess it's just preference, but I would want a tissue. So
I would want to. I don't know, Risha, Donna, Pat, Christy, Jason, with your lived experience, what would you? Oh, go ahead, Courtney. Sorry.
No, I was just going to say, I think I just make sure they're always available. Also, just have the tissue somewhere the patient can reach them. If it's my own personal office. So when I'm not a student, that's my plan.
Exactly, and not the crap ones that the hospital gives you, the good ones. Don't
give me the puffs with the lotion. I'm fine with that. Have them available. You never know how any parent's going to react.
Maybe have also ones without lotion, because some people have allergies. Sorry.
No, you're totally right. No, but
just don't clean your glasses with
you
them.
haven't seen the ones that we get at the hospital, though. They're like sandpaper.
Well, I have those toilet paper at universities too.
Yeah, true. Yeah.
I think I would just value having it in sight, but not being being implied that I'm going to need it. Cause I'm the type of person that I'm going to shut down and process probably once I'm out of the room.
Yeah.
So I like the idea if it's visually easy for me to find, but not implied and held for me.
Yeah, I think it goes with it, having it available. And then if you've seen somebody crying, maybe offering it. But, just as different people have different reactions, and sometimes I cry and sometimes I don't. And it doesn't mean I'm not feeling something. But then sometimes you feel that, because there's also these shame we put on parents and other people of I should be feeling this emotion this way because there's offering a tissue might also or without them crying, or might make somebody feel like they should be reacting this way.
No, I appreciate that conversation, because I think that it's one of those nuances that can make people feel really awkward. Are we on it? Oh yeah, Elodie, yeah. Mm-hmm. Oh yeah. Yep.
I gave a parent a tissue today.
Yeah.
He started crying right away. And I was like, it's okay. This is hard.
Yeah.
That's
hard.
it's okay, this is really hard. You know, like I
Exactly.
think that normalizes it. And I think it's
Mhm.
like Shannon said, sometimes it's support and it's letting them know that like it's okay, you know, like
Yeah.
I'm not here so that you can minimize how you feel and how hard
Right.
this is. Like that's not the point.
And I love that. Like, yeah, this is hard. We're here for you. And that's what I always try to communicate and a lot of the work that I do, not in necessarily in feedback sessions, but just in general, like this is a journey. This isn't a cancer diagnosis that we will hope that a treatment will, you know, get your child into remission or get you as the patient into remission. This is a chronic health, you know, some people call it condition, some people call it diagnoses. These are differences in the way in which our brains function. And so this isn't something that is going to go away. And it's a different type of experience, I think, that our families have on that end. In some cases it is, it's a huge, nothing is mutually exclusive. You can be relieved that somebody hears you. You can be scared about the future. You can be sad, and it all is wrapped up in the same conversation, right?
Well, and it's going to be like some really good things, but it's also going to be tough, whether because of some of the things that happen to the person themselves, or because we live in a world that still it still sees disability as just individualistic and just about coming over things. So even if you have, because there's a lot of parents who I've met who also have who have really good attitudes about it, or learn, like it's just who they are. It's just, but that doesn't take away that there's going to be challenges, because even though you love your child and accept who they are, the world doesn't necessarily. Sorry, not to be on my high horse.
No, you bring up a really good point too about that experience that the caregivers themselves have had, or the grandparents maybe have had, in the struggle for their own children and their own child's education. Or I can't tell you how many times I've talked with a family about their child's diagnosis, and mom or dad said, well, I was in special classes, or, I don't want to use the MR word because that's what people called me growing up. Right. So they live their experiences out too. And that can come out. So absolutely. Let me jump back into the slides. We have a few more. So we've kind of talked about some various theories and approaches to dealing with emotion, which I think the ultimate takeaway is that needs to be genuine. It needs to be genuine. And that's going to be more off-putting than anything, is when it's not authentic. My son saw a doctor recently, and it was weird. He kind of coughed, and the doctor like awkwardly like pat him on the back. And I was like, ooh, what was that for? And so it just be yourself, be genuine. Elodie's like, yeah, that's so weird. Like, yeah, I know. I was like, oh, okay. So, okay, we've talked about addressing this, but it's really hard to keep, like I said, we don't want to barrel people over with information when they're not ready for it. And this is maybe when you check back in and get that invitation again of, let me know how much, how we want to use the rest of our time together. And it's okay if we want to end now. Right. So it's really kind of getting back to that validation. We've talked about working through that emotion and really just letting people know whatever they're experiencing is natural, right? People have all kinds of different experiences, and whatever they're experiencing in that moment is okay. And that's, I think, the hardest part. And we can talk and talk and talk, but that's what we'll practice in the role plays. And then obviously the strategy and summary is kind of having one or at most two steps. And I think that this is what's so challenging, and what I love about our ITT cases is that there's so many disciplines that see a family, and we all maybe see something, but how do we really focus on the one or two takeaways that the family can move forward on? And then maybe have some back burner items that, like, okay, in a month or two, let's get ready for that. And you may not get to this. You may have an appointment with a family and not get to this. And that's when then you kind of use that team-based approach of, okay, Andrea, I saw this family for therapy. It seems like you had met with them and done an initial ISS, shared some diagnostic information. They came to me, they saw some questions. I wanted to let you know where their questions were so that when you see them back in 3 months, you can pick back up, right? So just always really trying to communicate your assessment of the health information that the family still needs or that the patient still needs. And again, this goes, we've already kind of talked about the reframe. Reframing is like, you know, social workers learn this a lot, counselors, I'm sure genetic counselors, you guys have talked about the reframe of, you know, there's so much to reframe right now around COVID. I remember my cousin, her son recently got a diagnosis, I think late last year. And she's like, well, if I hadn't, you know, had to sit him in front of the TV so long, he probably wouldn't have autism. And my reframe was, I'll be honest with you, like, it's not just environmental, and there's a lot of other things that go on, and please don't blame yourself for, you know, what you had to do to survive the pandemic. It is way more than just having him sit in front of the TV. And so, and really trying to think through, and that goes back to that critical thinking piece of how do we kindly and compassionately dispel people's, dispel what they misconstrue in their own mind, and kind of help relieve some of that guilt, blame, stress. And then this is where we have also that kind of end point of balancing between reality and hope. And so one of the things that, again, I love our Family Advisory Council. So years ago, they created a booklet called the Sharing Hope booklet. And it was really a collection of stories of individuals with disabilities that are seen in the division, their family members, their siblings. And oftentimes this is, you know, handed to families, you know, not in COVID when we're doing information sharing sessions telehealth wise, but in person to say, you know, we're here for you for the journey. And here are some people's experiences. And really the idea was sharing hope, sharing that you're part of this community and we want to walk this journey with you. And we're going to be here for you. And then always offering a person, a time for future questions to be answered. So I want to I love this Maya Angelou quote because this is why we do the role plays with the actors. And it's something that we put some grant dollars behind because we think it's really important, because it's how you're going to take away that experience for how you felt in the moment, but think about how your patients feel in those moments as well. So let's see. I kind of am getting the vibe that we want to be done. So I'm going to read the room and I'm going to say, we're not going to do the video example, but I am going to make sure that the other video works. And there's some other resources on Canvas. There is actually an Autism Speaks toolkit, and I know Autism Speaks is not everybody's favorite thing, but they did have some folks at another LEND program a number of years ago put together a toolkit about sharing an autism diagnosis that I actually don't think is bad. And then there's some other just materials out there, and I'll hunt some others. There's been some other videos that I can put online too. So watch some videos, talk amongst your friends about how this might happen, and then I will let you guys go. And I will also post and announce the groupings, the pairings, the observers, all of that for the role plays so that you can get connected with the people that you're with. If you are an observer, you will see on Canvas that day the family-centered care form, and then you'll see a handout that also includes the SPIKES protocol. So you can provide some typed or written feedback to the people you're observing about, oh, you did a really great job, like clearly making sure that you limited distractions. That was great. Or, oh my gosh, the mom got really emotional and you did an amazing job when you said this. Like those would be the kinds of pieces of feedback that we're looking for. And we are going to be virtual still, so just be mindful of that. And if you have questions, I'll be around, but please try to make sure you check canvas for your assignments and get in touch with somebody before you take off for spring break.